Probably about 1 in 10 of our patients come to us for assistance not because they can't get pregnant, but they can't stay pregnant to fulfill the entire timeline to have a baby and a healthy baby. And when this happens more than once, let's say 2 or more times, you're not quite sure, are you paranoid or is someone following you? And it can be tremendously stressful. My wife and I experienced 3 losses ourselves, but we didn't give up, and persistence is a long, strong suit to have in this situation. But this is what we call recurrent pregnancy loss. And there can be different causes for this. Sometimes it is truly random, and there isn't a specific cause found. But if we're playing fertility CSI here, we may consider organizing this into 4 main categories to look for. One is genetic, another is anatomy of the uterus itself, another one is hormonal, which could be thyroid, pituitary gland issues, or even the hormones that detect lower ovary reserve that might imply lower egg quality. And then the 4th category is immune. So I just wanted to cover these in a little nugget here. From the genetic aspect, either partner can be carrying an abnormality in their chromosomes. And it's important to get a karyotype test, and that's a blood test where they're going to look to see, do you have the right number of chromosomes, which should be 46, 2 of each, and also to make sure each chromosome contains its appropriate components. Each neighborhood should have the right number of houses in it, and each chromosome's a neighborhood. Sometimes you get half of a neighborhood swapping with another neighborhood. So if you have, and I only have 5 fingers here, if you have 5 chromosomes, and my thumb swaps with my index finger, I'm all thumbs here and none over here, I still have all my genes, but there's been a rearrangement, what we call a translocation. And if it's been an even swap or balanced, since I have all my genes, I live. But if I have to cut the chromosome deck evenly and only give half of my chromosome material, and my wife gives the other half, I can be giving too many thumbs, or not enough. And the embryo that forms and is growing in my wife's womb may be misprogrammed and may not survive as an unbalanced rearrangement or translocation. So when we see recurrent losses and we test a couple for the chromosome abnormalities, what I just described, a translocation, is the most common abnormality we will find when we find one. But how often do we find it? Maybe 1 out of 20 times. So it's the most common thing among a relatively uncommon cause. But we need to check both partners for these things. And if we do find an abnormality, then we may consider in vitro fertilization and pre-implantation genetic testing to see whether or not an embryo has a balanced rearrangement or not. The technology is still not good enough to know every house in the neighborhood is in its right, in its right street. But we know if it's balanced, that embryo can lead to a healthy person just as the affected parent. And if it's not balanced, then we would select not to use that embryo because that would be fixed to fail. A final example on this would be one of my patients who we're caring for now has a lovely little boy at home, had to go through in vitro fertilization. We had 8 embryos to do genetic testing. How many came back normal? 1. She had had 6 miscarriages prior to this effort. How can we avoid the pain and agony of that experience? If we learn about this, there is a pathway. But there still is a challenge that is still up to someone else upstairs as to whether we can get at least 1 normal embryo. The second thing is on the anatomy of the uterus. There can be polyps, fibroid tumors. A woman can be born with an abnormal shape to her uterus. So the uterine architecture can play a role in this. And there's certain testing that we can do, saline sonograms, ultrasounds, to identify these problems and look to surgically repair them. But if the contour and shape of the uterus is normal, then we have to move on to look for other causes. The third category is hormonal. Some women that have thyroid disorders, either overactive or underactive, may have imbalances that lead to not having regular periods, but also there's been an association with an increased risk of pregnancy loss. So being able to manage those thyroid imbalances and bring the thyroid function, what the body receives in thyroid hormone, into normal balance may reduce the risk of miscarriage. Beyond that, ovary reserve may be another issue for women, and egg quality can be an issue. Our tests for ovary reserve include an anti-Mullerian hormone, AMH, a follicle-stimulating hormone, FSH, and looking in the first 3 days of a period at the number of little resting follicles on the ovaries. This is our best way to look for egg quantity, but we have no test to look at egg quality. That is a blind spot in our fertility evaluation. However, if we see evidence of abnormally low AMH, meaning the gas gauge is low in the car, at abnormally high FSH and a low follicle count, then there's low reserve. And quality may not be far behind the low quantity. And that could be a clue, as it is for women of advanced reproductive age, over 40, that miscarriages are more common. The fourth category for causes of recurrent pregnancy loss is abnormality of the immune system. And there's one particular abnormality that we've been able, through evidence-based medicine and science, to say this is a cause. And it's something called antiphospholipid antibody syndrome. It's rare. There aren't many women that truly have this condition. But when this condition exists, it can interfere with the placenta staying attached to the wall of the uterus, and in essence, start attacking the placenta to separate it. And this can happen at any stage in pregnancy. So there are certain tests that can be done, as anti-cardiolipin antibodies, the lupus anticoagulant, and something called glycoprotein testing that can be done. And if we see an abnormality in these antibodies and they're high, and we check it 3 months later, and they're still high, this is a consistent issue, then we consider our remedy of using a very low dose heparin-type medicine and baby aspirin. And this can neutralize the effect of these antibodies and improve the opportunity to make it all the way. There are other areas of immunology that are under intense study, but there isn't strong evidence for their advantage, whether it's natural killer cells, HLA haplotyping, which is human leukocyte antigen identifiers on cells, and there are certain remedies that are offered that are not only unclear to be effective, quite expensive, and potentially have risks, which include intravenous immunoglobulin therapy, for which you're garnering serum from many people that can even contain viruses that we cannot detect, called prions, that can cause mad cow disease, Kuru, Jakob-Creutzfeldt. So there better be a good reason with a good outcome for that kind of intervention to take on those kind of risks, but it's commonly done. And other immune testing to maybe even transfuse white blood cells from a male partner into the female partner, trying to activate the woman's immune system, can also lead to serum sickness, anaphylaxis, shock, and problems that way. So these are sometimes prescribed based on tests that have not been approved by the FDA or undergone peer review to be reliable tests. And there are pockets in the country of physicians and centers that offer this testing, but it's not something I would recommend, and it's outside the realm of what the American Society for Reproductive Medicine clinical guidelines would recommend. The other final thing is, in immunology, is also blood clotting disorders. And although that's not a direct immune issue, we know when miscarriages occur, bleeding occurs. And there are certain blood disorders that can lead to blood clots during pregnancy. But the tests that are frequently done is a routine when there's no family history of blood disorders or clotting disorders, have not been shown to be directly related to recurrent pregnancy loss. And the guidelines by the American Society of Reproductive Medicine strongly discourage these tests from being done, even though historically they've been done for years. Habits are hard to break. In closing, when no abnormality is found, there's still good hope for success. Because when no abnormality is found, when we follow our folks up for 2 years, at least 70% go on to have a child. So even if it seems you're defeated that we didn't find something to fix, persisting tends to rule the day, and there really is good hope.